Okay, so let's talk about cellular hypoperfusion or shock. This is one of those things that I want you to really kind of frame in terms of the cells and what's happening in the cells. Yeah, we think of shock as like low blood pressure, but that tends to be a pretty late sign of what's going on here. So, shock, think more at the cellular level, and it's cellular hypoperfusion. The cells are not getting enough blood, therefore, they're not getting enough oxygen and glucose to create energy. So this is at the cellular level. When we think of shock, we got to first kind of talk about cardiac output. What is the heart putting out, and in terms of its blood flow to these different tissues. So cardiac output, simple equation of heart rate times stroke volume equals cardiac output. So heart rate is pretty obvious. Heart rate is the number of beats per minute, right? And stroke volume is going to be the amount of blood pumped with each, that's pumped out with each beat. So stroke volume, pretty complicated sort of concept here, though, is built up of three different components. We have preload, contractility, and afterload. Right. So preload is blood returning back to the heart. Blood is returning back to the heart and is going to stretch the heart more. The more blood that kind of comes back to the heart, the more it stretches it, the more it's going to squeeze. This is something called Stirling's principle. It's an important concept in terms of creating the conditions for us to get a good heartbeat that's going to pump a lot of blood out of it. So, our preload, very important to stroke volume. Contractility, how strong is that cardiac muscle going to be at actually pumping that blood, at expanding and then contracting with this squeeze? So, how strong is the squeeze itself? And then afterload is going to be the sort of what is the blood getting pumped into? And sort of you think of the diameter of the blood vessels being the sort of critical component to this. Uh, and more constricted blood vessels going to be kind of harder for blood to get pumped into it, but under a higher pressure. More dilated vessels, blood's easier to kind of pump into it, but at a lower pressure, so it might not go as far. So afterload is very important in terms of cardiac output as well. So these three things are going to create stroke volume, which times that by heart rate gets our cardiac output. Let's talk about the types of shock. So we have our four major types of shock. The first is going to be hypovolemic shock. So hypovolemic shock, inadequate blood volume in order to maintain perfusion status. And so we have a couple of ways that this might happen, but this just is really a matter of losing that volume. So we have obviously bleeding. If you have extreme amounts of bleeding, whether that's internal or external, that's going to lead to hypovolemia. Vomiting leads to hypovolemia and diarrhea. These are two very important ones, especially for our pediatric patients and elderly patients. So, something just to remember about that. Burns also are going to create a sort of hypovolemic state just because the fluid shifts out of the vasculature and it shifts into the tissues. And this is a big problem because it's obviously not able to, you know, create perfusion when it's in the tissues, need it to be in the circulation. So that's why burns are these kind of special version of a hypovolemic shock. Next, we have cardiogenic shock. Cardiogenic shock has to do with the heart muscle itself, inadequate function of the heart muscle, and so it impacts its ability to pump blood. We think of the classic example of myocardial infarction as one of these cardiogenic shocks. Heart failure can also be this in its many sort of forms. So we think of cardiogenic shock being specific to the myocardium of the heart, the tissue, the heart tissue. Different from that is going to be obstructive shock. Now, this is going to be a mechanical obstruction of the cardiac muscle and its ability to pump. This has the cardiac muscle isn't the actual problem. It's something external to it that's creating situation where it's not able to pump well or perfuse well. So cardiac tamponade, fluid surrounding the heart, obviously makes it hard for the heart to pump, expand and contract within the pressure that's created from this. I want you to think of like a submarine at the bottom of the ocean and all that pressure around it and its inability to kind of expand and contract. Similar sort of idea with tension pneumothorax. You have all this pressure building up and it's impeding the ability of blood to get back into the heart because it's kind of under the pressure of the vena cava is collapsing. So blood flow preload is being impacted significantly as it comes back. But then also pressure is being built up in the thoracic cavity around this heart, and it's still unable to really pump as well as it's normally able to either. And then pulmonary embolism, an obstruction within the vasculature of the lungs. And so you can imagine that this is going to create back pressure into the right side of the heart as it's trying to pump into an area that is going to not, that's going to be obstructed, that's going to block it. So this is, again, something mechanical obstructing the ability to pump blood of the heart. And then finally, we have distributive shock, widespread dilation of the blood vessels, and this is going to result in inadequate pressure for perfusion. So we have three examples here. The big examples, we have sepsis. Sepsis, these cytotoxins are going to release into the system, create vasodilation and low blood pressure. Um, pH problems, acidosis also does not help any of this sort of stuff. Neurogenic shock is going to be some case where either the brain or the spinal column is impacted, and so you wind up with this hypotensive state. The parts of the brain that control constriction and dilation of the blood vessels gets interrupted, so they wind up in a dilated state. And the anaphylaxis, as you guys hopefully know, we have the dilation of the blood vessels due to the due to the histamine and some of the other cytotoxins that are going to affect the blood vessels. So that leads to our distributive shock state, our shock state. And just remember that there are stages of shock. We have our compensated shock. So our compensatory mechanisms are maintaining our cardiac output. So during compensated shock, our increased heart rate, our increased ventilatory rate, our as best as possible vasoconstriction, these things are working. These things are maintaining a blood pressure. They're maintaining perfusion status to our tissues to some degree or another. We might start shunting blood a bit away from things like skin and things like this to, make sure that we're bringing that blood flow to the most important areas. But our compensatory mechanisms currently are working to make sure our major tissues are being perfused. Once we get to decompensated shock, these mechanisms aren't really maintaining cardiac output anymore. They're trying, so you still see decompensated shock with high heart rates and respiratory rates and all of this sort of stuff. But by the time you start seeing decompensated shock, you're going to notice that heart is having a hard time here. And you're going to tend to start to see those vital sign shifts, especially blood pressure is going to start drop during the decompensated stage. Now we finally get to the irreversible shock stage. This is where you wind up because of that hypotension, that loss of perfusion status for a while. The cells themselves and the organs, the tissues of the organs are dying, and this leads to the death of the patient. Even if we could get return of normal perfusion, unfortunately, the damage is already too extensive and too widespread. Our renal system, our liver and our heart, our kidneys, our brain, everything is no longer really working. So it's just not going to help, unfortunately. You can wind up with this disseminated intravascular coagulation. So, due to a lot of really complicated reasons, you wind up with these microclots, and these microclots wind up in all of your organs. This is going to decrease your actual ability to get blood flow to those organ tissues. Those organs start to fail, and this is what leads to our sort of MODS, our multiple organ failure death sort of syndromes. These um, these patients, everything, like we said before, is failing around them, and this is just this sort of snowball effect of shock as we, unless we are able to intervene.